So Dr. Borek Foldyna will be joining us. He has already joined on Zoom with us. And the next talk will be a recorded lecture by Dr. Borek. We will be playing it, and Dr. Borek is definitely there to answer all the queries what we have. Welcome, Dr. Borek. Good morning from our side. I think it must be midnight there.
Thank you very much.
Yeah, we will start with the lecture.
Transcatheter aortic valve replacement. Specifically, I will show you how the method developed for the last 2 decades and what role CT imaging plays in the preoperative assessment. These are my disclosures, none of which is related to the current talk. So let's start with a brief history lesson. As you see here on the left, this is the first TAVR procedure. It was done over 20 years ago by this gentleman on the left here. His name is Alain Crivière, and he is on the photograph together with the first TAVR patient. First procedure was successful and done on April 16, 2002 in a little town called Rouen in France, just north of Paris. And as you can see on the right, the valve was rather provisory. Due to the success of the procedure, TAVR has become a main interest of multiple trials and also in the interest of the industry. Multiple large randomized control trials showed that the method is safe and effective. One of the landmark trials was the partner trial. As you see here in the trial was actually 2 separate trials that were independently powered. These trials enrolled patients with severe aortic stenosis and high-risk preoperative risk. The partner A was looking at patients with high risk that were randomized into TAVR versus SAVR, so surgical aortic valve replacement. And partners B was a trial that randomized patients that were at extremely high risk, so they were actually not suitable for surgical aortic valve replacement. So these patients were randomized into the TAVR group versus standard medical therapy. And if we look at the results, we see that the partner B, where we compared TAVR versus standard care and this extremely high-risk patient, we see that the TAVR group had a much, much lower mortality rate in the standard therapy, and this result was seen across all subgroups of patients. There was no one single subgroups where the standard therapy would be better than the TAVR therapy. In the partner A, the results were similar after 1 year between TAVR and SAVR, so between the transcatheter and the surgical aortic valve replacement, as you can see here in the Kaplan-Meier curves on the left. But there was a considerable difference between those 2 methods regarding perioperative complications. So the TAVR group experienced more frequently strokes and vascular complications, while those who underwent surgical aortic valve replacement had more frequently major bleedings. Looking at the long-term outcomes, we see that these long-term studies actually confirmed the first trials. So we see again the similar results between TAVR and the surgical aortic valve replacement. And the partner B, we see much better outcome in those who underwent TAVR compared to standard therapy. However, it's important to mention that especially the number of patients in the standard treatment group was very low in the last couple of years, which is definitely a limitation of this study. But these are not the 2 only trials that have been done with TAVR in the last, let's say, 10 years. If you look at here, there are multiple other ones which were published, and we see one thing, and this is the shift from the high-risk patients to intermediate risk patients, and the newest trials that are being performed are actually low-risk patient trials, and these results were all favorable, and we see that these results resulted in recommendations in the European and the US guidelines that 10 years ago recommended TAVR in those with high risk or extremely high risk patients, and now these guidelines only recommend TAVR in patients with intermediate and high risk, and I think that low risk recommendations are coming very soon. So these promising results from these multiple randomized control trials led to the pretty much explosion of the TAVR numbers. These are numbers from the STS-ACC registry here in the US, and we see that already in 2015 the number of TAVRs actually surpassed the number of isolated surgical aortic valve replacement. And in 2018, the number of TAVRs surpassed the number of all surgical valve replacement here in the US. And we expect that in 2025, the TAVRs will represent around 75% of all aortic valve replacement in the US. At the same time, what we see is that the patients which are undergoing TAVR have increasingly lower STS scores. So we see that patients with increasingly lower perioperative risk are undergoing TAVR here in the US. And here on the right upper corner, you see this map. And this map shows you actually that there are increasingly more and more centers in the US that perform TAVR. At the same time, as we see that the length of the stay went down considerably, we see that the discharge disposition got better over time, and we see a lowering number of complications such as stroke and need for pacemaker implantation. And this is mostly due to multiple factors. One of the factors is the development of the valves. Here on the left, for example, we have the balloon or mechanically expandable SAPIEN valve around 10 years ago, and now the mostly implanted valve is the SAPIEN 3, which looks considerably different. On the right side, we have the self-expandable, for example, core valve, and which was developed to the most recent iterations, which is called Evolute Pro. But as you can see here, there are numerous other valves in development. There are more than 10 upcoming randomized control trials looking at all these other valves as well. So there is a lot to come our way. So the factors related to positive outcomes are, one, the expertise. So we see much better patient preparation and selection. We see much better improved and streamlined heart team collaboration between cardiologists, cardiac surgeons, radiologists, and the entire team. We see this device evolution of the valves. For example, if you look at the SAPIEN 3, it has a little balloon around it, which is expandable. And as you can imagine, this is going to seal the aortic annulus despite extensive calcification. It's going to automatically lead to less paravalvular leaks. And of course, improved pre-procedural imaging has changed the outcome considerably. So we have now better device selection, device positioning. We have better access route planning and identification risk factors. So if you remember the PARTNER 8 trial, which showed that TAVR patients have much higher, for example, rate of vascular complications. Here is the role of the CT to identify, for example, the stenoses and calcification of the access routes and provide alternatives. So let's look at the CT imaging for TAVR planning a little bit more closely. So what are the recommendations at the moment? So there are these ACC and JCCT published guidelines for imaging prior to TAVR. And the consensus is that CT is a gold standard for annual sizing, determination of risk for annual injury, and coronary occlusion. And this is an updated version from 2012. And if you look at a recommended imaging series, then we see that we should always image the aortic root, the aortic arch, and the iliofemoral axis. The aortic root should be imaged with ECG synchronized acquisition. The aorta and iliofemoral axis do not require ECG synchronization, so we can save a little bit of radiation here. We should optimize our image quality. We should provide images with a very thin size thickness, optimally equal or below 1 millimeters, to allow for multiplanar reconstructions. In patients with impaired renal function, we can consider low contrast protocols, and beta blockers are not recommended while nitroglycerin is contraindicated in these patients. So let's look at an MGH case example. So here at MGH, we start our scans with localizers in two directions, AP and right to left. And we use these localizers to do the next scans. The next scan is the non-contrast image of the heart. And here we use these images, for example, for the calcium scoring of the valve, but you can also use it for the calcium scoring of the coronary arteries if needed. We also perform an imaging of the aorta using this non-contrast imaging. So here we can look at, for example, at circumferential calcification in the area of the abdominal aorta or the iliac vessels. These images are followed by a multi-phase cardiac CTA, so we have usually all phases, especially the systole is imaged. We are using the systolic images for the sizing of the aortic annulus and of the aortic root. But here also you can look at the movement of the valve and, for example, dissections in these areas or other relevant cardiac findings, for example, the coronary arteries. This imaging is followed by aortic CTA. In the aortic CTA, we are looking at access routes. We are looking at the aorta itself, where there is a kinking or extensive calcifications or dissections. And we are also looking at the access routes, including, for example, the axillary or subclavian arteries or the iliofemoral axis. We provide the axial images, but also the corresponding coronal and sagittal reconstructions. And the last scan we perform is 100 seconds delayed images for incidental findings and for exclusion of thrombi within the veins. We are lucky here at MGH. We have a 3D lab. This 3D lab helps us to prepare all the reconstruction we need. For example, they provide this beautiful 3D imaging of the aortic valve. They do the calcium scoring. They provide us with the angulation of the aortic root for the C-arm. And they also perform all the 3D measurements using the MPR mode and give everything in a standardized report. The standardized report looks like this here on the right. It's very important standardized reports with the increasing number of measurements that we provide. It summarizes all relevant measurements. It adheres to the 2019 SCCT guidelines. It's based on 2D and 3D MPR measurements, and it's performed by our 3D lab, as mentioned, on an Aquarius Theory workstation. And all values listed in this report are also available as MPR screenshots to assure accuracy. So every number you see here, we can find in our saved screenshot unpacks, so we can check every single of these numbers. So let's start with the measurements. So let's start with the aortic annulus, which is the most important measurement and the center of our report. We angle first the annulus, which is a virtual plane aligned with the most basal attachment points of the valve cups, as you see here in the red arrows. It's crucial for the prosthesis sizing. It represents the landing zone of the future valve. And we always measure in the systole, since in the systole, the annulus is the largest and it's also the roundest. Otherwise, it's kind of oval and smaller. We recommend to use the cubic spline for the perimeter measurements. Otherwise, we provide the diameters, the maximum and the minimum diameter. We also provide the area, the average diameter, and as I said, the perimeter. If somebody is interested in how to angle the annulus plane, there is a nice step-by-step description in the current guidelines, which guides you through the MPR process, how to get all the measurements, and also shows you how to measure the area, the perimeter, and the maximum and minimum diameters. Further down the road, we will look at the calcifications. So our 3D lab provides a calcium scoring, which is based on the Agatston score of the aortic valve. We also look at the distribution of the calcium. We provide a qualitative assessment of the annular calcifications, providing 3 categories: mild, moderate, and severe. And we also report whether these calcifications include or affect the aortomitral continuity, since we know that extensive and especially centric calcifications may lead to paravalvular leakage or annulus injury during the implantation. So therefore, we provide information on morphology, extent, and relation to cuffs. The other information we provide are the leaflets and coronary ostia. Here we provide the distance from the ostia to the hitch points of the aortic leaflets, and also the distance of the ostia perpendicularly to the aortic annulus for right and left side. We also provide the length of the aortic leaflets, and we provide the dimensions of the aortic sinus. This is very important because, as you can imagine, if you have a long leaflets, a very short distance between the ostia and the annulus, and bulky calcification, this can lead to a coronary occlusion, and we know that coronary occlusion is relatively rare. The incidence is around 0.7%, but is associated with very high mortality, up to 41% in the first 30 days after the procedure. And we know that ostial height below 12 millimeters, especially in combinations with a narrow aortic sinus below 30 millimeters is considered increased risk for coronary ostium obstruction. So always look for the narrow sinus with a low origin of the coronary ostia in combination with long calcified leaflets. The other information we provide are fluoroscopic angulations. Here, we know that these angulations shorten the intervention time, they spare radiation and contrast media, and provide relative position of the esophagus relative to the TEE probe, which improves the orientation of the surgeon and of the anesthesiologist during the procedure. The next information we provide are the access routes. So we describe the most common one is the transfemoral one, followed by transapical, or for example, subclavian or axillary. But there are less common ones described in the literature, including the carotid access, suprastenal access, direct aortic, or transcaval access. So why is it important to report on a vascular access? We know that the vascular complications are independently associated with increased morbidity and mortality after TAVR. The complications rate have fallen to 4.5%, especially if you compare it, for example, to the Partner A trial, which described 18%, which is wonderful, and I think mostly due to the improved imaging and preoperative preparation. We described the stenosis, we described calcification, also the tortuosity of the vessels, and we know that the sheet to minimal diameter ratio of equal or larger than 1.12 is considered safe, and we are looking for diameters that are optimally larger than 5 millimeters. So we usually report a minimal luminal diameter along both right and left iliofemoral systems. We provide information on circumferential calcification, especially those which are exceeding the 3/4 of the circumference of the vessel. We also provide information on calcifications which are located anterior at the site of probable puncture, for example, in the area of the common femoral artery. And we report on aneurysm dissections and occlusions. And the current guidelines also recommend to look at coronary arteries as long as we have sufficient image quality. Remember that these patients usually do not get beta blockers, and nitroglycerin is contraindicated. That's why the image quality is not as good as in a normal coronary CTA. This is how our vascular access looks like. Here we have the thoracic aortic branches. We describe the brachiocephalic artery, the axillary artery, and the subclavian on the right and on the left. We describe the aorta itself, so the diameters of the ascending aorta, and we are looking for the maximal diameter of the descending aorta. Then we also describe the minimum diameter of the aorta, which is usually here in the abdominal portion, and we look at both runoffs here on the right side and also on the left side. Here we are looking for the minimum diameters which are less than 5 millimeters. For this particular patient, the minimum diameter here is on the left 5.6 millimeters and 7 millimeters on the right. So both areas were suitable for TAVR. The second thing what we are looking for is kinking and tortuosity. That's why we always provide also the 3D reconstructions. So this is a sum of our report. We have the information of the optimal C-arm angles. We have the information of the aortic root with the height of the ostia, length of the leaflets, and also the height of the sinus itself with the sinotubular junction. We provide the information of the annulus with the diameter, area, average diameter, and perimeter. We provide information of the diameters of the aortic sinus, and we also provide information on the calcium score of the valve, plus the 3D imaging and the minimum diameters of our access routes. To sum up, TAVR is now approved for high-risk and intermediate patients, and we see that increasingly low-risk patients are considered for TAVR, which also leads to new challenges. Preoperative risk assessment is crucial for the success of a TAVR, and we know that imaging plays an increasingly important role before, during, and after TAVR, and CT is the method of choice for preoperative imaging. Thank you very much.
So Borek is available with us
So
for
everyone, my name is Borek.
question and answers.
In the next 20 minutes, I will be talking about CT imaging prior to transcatheter aortic valve
Borek, you can
replacement.
unmute yourself.
Specifically, I will show you how the
That was a
method
great
for the
talk.
last 2
That
decades
was really
and what role
going
CT
right
imaging
through
plays in
all the
radiographic
aspects of TAVR
assessment.
that is needed. In the last whatever
These are my
talk that we
disclosures, none
had,
of
there
which
was a
is related
question
to the
on
current
where
talk.
do you have your cutoffs
So
for
let's
the
start with a
calcium
brief history
score
lesson.
of
As you
the
see
aortic
here
valve. So
on the
do you want to
left,
give us
this is
some
the first
perspective on
TAVR
that?
procedure was done over 20. Yeah, I think I still can hear my talk. I don't know. Is it still running?
Can you hear
Oh,
us?
here we go. Yeah, so we use usually the cutoffs what I showed on one of the slides. It's, I think, 2,000 for men and 1,200 or 1,300 for women. That's, these are our thresholds. I heard the discussion. I think what's also possible, I don't know if it's done at your center and on a daily basis to measure the AVA, the aortic valve area. And you can grade the stenosis with that as well. And I mean, I think you mentioned that the density plays a role. I totally agree, because you know the traditional Agatston score is 30 years old and it's weighted highly towards the higher density, and maybe a volume would be a better measure for the aortic valve if we are really looking at bulky calcification of obstructive movement.
You know, about aortic valve area, I'm always a little skeptical about us doing it because the echo always comes up with some number, and we are very, very precise, and we can actually tell where to do it, and then it's not really, it doesn't always match, and it just creates a whole lot of confusion. So, what's your take on that?
I totally agree, and at the end of the day, if you have a symptomatic patient who has aortic stenosis, you need to treat that, right? So it really doesn't matter if it's, you know, 8.8 or 1 square centimeter, it really doesn't matter. And the calcifications are really more important to, you know, the symmetry of the calcifications. For example, bulkiness is more important than, I think, than the number itself, just to really decide on what valve you are going to take. You saw all the different valves. So for example, core valve, which is self-expandable, doesn't have so much force to actually pull the calcification to the sides, and we know that this valve leads more frequently to paravalvular leakage than, for example, the Sapien 3, which even has this sealing ring around it.
Yeah, totally agree that, you know, also there's all these, the shape of the calcium, which is so important, because I think that's really more critical than the quantification of the calcium. And yeah, Tarun, you have a question?
Yes, no, thank you, Mona, and thank you, Dr. Foldyna, for your comments. And I think both calcium of the aortic valve and aortic valve planimetry on CT we can do very precisely because we know the limitations of the effective orifice area that's measured on the transthoracic echo. You know, it's based on a fallacious smaller alveolar diameter. And we can provide much better diagnosis, I feel, in patients to confirm if they have severe aortic stenosis. And as diagnostic radiologists, I think it should be our responsibility to confirm the diagnosis, because in my own analysis of around 500 cases where we have done CT for TAVR planning, about 20-25% patients do not have severe aortic stenosis. So this is an area of, to me, it's an area of growing concern where patients are being diagnosed, over-diagnosed with severe AS. And it's simply, I think we have to be like guardians of who undergoes TAVI procedure, who does not undergo TAVI procedure. And we are not simply there like technicians doing CT scans and doing some measurements.
That, you know, I agree.
That is not our primary role. We are diagnostic radiologists. We are there to diagnose disease. That is where what we should be doing. But the problem that comes up
is that because of the calcium, the shadowing from any echo study that we know from every ultrasound study, it always overestimates the amount of stenosis. And we, on the contrary, do a much better job of it. But the problem is, on the last minute, are you going to just defer the TAVR and throw them up in the air? Well, your cardiologist ain't going to like you very much.
Absolutely.
And the same thing is happening with mitral also, where you have moderate mitral regurgitation, but that's also happening with BIRAD 3 and LIRAD 3. So are you going to go to the 4 or the 2? It's always a tricky question.
No, I think we will be discrepant in about when we say that We'll be discrepant in about 1/4 of cases, but we have to challenge the diagnosis and make our cardiology colleagues, colleagues, look at what they are seeing a bit more better.
Borek, any comments?
And make them a part of this.
Yeah.
You know, it is not, we are all working towards a better diagnosis for our patients. And
Agree.
we want to select the right patients who are going AVR or TAVR procedures.
Agree.
That's
We need to set the compliances.
No, I totally agree, definitely. Yeah. And I think, you know, I talked that one of the reasons why the outcomes got so much better is the communication also between the teams, right? It's the heart team which we have at the moment, which are usually surgeons, cardiologists, and radiologists. And there should be a two-channel discussion, right? It should be a back and forth. So if I see, of course, if I see a huge discrepancy, I'm asking myself, okay, why does this patient with 0 calcium needs a TAVR measurement, right? So I usually reach out to the cardiologist and ask them, and they usually give me an answer. Okay, it's a bicuspid valve, for example, and they are just looking at it as an option, right, for this, I don't know, 80-year-old patient. So it's a discussion. I totally agree.
Great. Sandeep wants to say something.
Yes, and so in my institution, we have dedicated heart teams which meet once a week for TAVR and once a week for non-TAVR related interventions. Every single echo that is done at an outside hospital is carefully reviewed. Many times it hinges on the way the tracings are done to get the peak gradient and peak velocity, and we find ourselves correcting that over and over again. So only after a team of cardiologists, cardiac surgeon, interventional cardiologist, and a radiologist has looked at all the images, then a decision is made whether or not to subject the patient for a valve intervention.
Even we have a very, very strict heart team. And every TAVR, before every TAVR, there's a discussion. And not only will we discuss it, like if there are 2 or 3 TAVRs a day, we'll probably have 3 meetings because they don't want to confuse one and the other and then, you know, be chatting, because there's always so many valves to evaluate. Which one are we going to put? Which one will be, how eccentric is the calcification? Are we going to get, you know, a circular valve at the end of it? So there's a lot of discussions that happen, and everything is sort of really thrashed through at the meeting before the TAVR insertion. But great, that was a great talk, and thank you so much. Thanks, Borek. That was very, very interesting. And I hope you're going to stay with us and continue to give us more info on whatever you feel about the structural heart. So, go on.
Yeah. So the next talk